Okay, so this is a pretty large topic. I'm going to narrow it down to the transolecranon fracture dislocations, and hopefully by the end of this talk, you will be able to identify which ones are this and separate from the other ones. So when we call an elbow joint, actually it's not single joint. There are 3 joints in the elbow, and when we are talking about elbow dislocation or fracture dislocation, it may mean different things. So for the wording, I think we're going to clarify which joint is dislocated or not. Usually for transolecranon fracture dislocations, again, I don't remember when I was a resident years ago, we had this term really taught to us. I think it came up in the last 5 to 10 years more often about a subgroup of elbow fracture dislocations that I think we recognize better now. It's not like it wasn't happening before, as I'm going to show you. The typical mechanism, again, so I think the mechanism of the kind of the forces defines this injury. Usually what you will have, a force on the flexed elbow, and the force goes through the forearm, pushing basically the forearm more anterior in this position. And the distal humerus goes the other way. It's like a distal humerus is punching on the olecranon and causing a shear force, and there's an ulnohumeral dislocation or subluxation. Again, this is kind of a more typical. You have disruption of the ulnohumeral joint. Commonly, PRUJ is intact, not always, but collateral ligaments are usually intact. So transolecranon fracture dislocations are commonly, the typical ones are a bony injury, and the ligaments are usually not involved. So it's not a soft tissue instability problem, it's a bony instability problem. Again, when I was looking at the olecranon fracture classification for another talk, I realized that this classification has been described a long time ago. Actually, if you look at the bottom part of it, these are transolecranon fracture dislocation. It has been described, it just, they didn't tell it, they included it as a part of the olecranon fractures. They are basically a severe olecranon fractures, not the typical one with the avulsion with the triceps. And ulnohumeral joint usually is located, the typical olecranon fracture. This is the more severe ones that ulnohumeral joint is being dislocated. Again, what is the difference between an anterior mortagia versus transolecranon fracture dislocations? Again, I put this 2 in there. Again, ulnohumeral joint is the key part. In a mortagia, is the radiocapitellar joint that's being dislocated, is not the ulnohumeral joint, versus in the transolecranon one is the ulnohumeral joint. There's the kind of the reverse of the what's injured, what's intact. Again, anterior mortagia versus transolecranon, the ulnohumeral joint is the key part that you're going to look at it. The other one is anterior elbow dislocations. The good thing, I don't think many people have seen any anterior elbow dislocations. These are super rare, usually in its younger patients too. So like a pediatric group of patients, and they're not very common. It's anterior elbow dislocations, primarily ligamentous injury, and associated with some epicondyle fracture. Unlike you are practicing peds, even pediatric orthopedic surgeons haven't seen that many because there are a limited number of case reports in the literature. So you don't have to think about anterior elbow dislocations much, because if you see in a peds patient, you would know what it is. And olecranon fracture dislocations, basically, I can put this in 2 groups, olecranon fracture and something is dislocated. If it's anterior, it's a transolecranon fracture dislocation. If it's a posterior, it's probably mortagia fracture dislocation. This has been described a while ago. If you start reading the literature and you start looking back at the references, actually it goes back in 1974 in a French article that has been described. Although in this days nobody reads anything, it's just everybody watches, at least my residents. They don't know how to read. So transolecranon fracture dislocation, I separate them simple or complex. When there's a combination of the greater sigmoid notch and proximal ulnar metaphysis, unfortunately this elbow fracture dislocations comes in different flavors, and this coronoid area may be broken, may not be broken. So that's why I try to separate them. In a simple one, usually the coronoid is intact. There may be some comminution, but the coronoid is intact and is attached to the proximal ulna. So it's not a coronoid causing any instability or anything. If the coronoid is involved, I think it becomes a little more complicated. It can be simple, it can be comminuted, and it comes in with different flavors, right? Proximal ulna may be broken in different parts. Radial head fracture sometimes comes in together, and sometimes you may have additional ligamentous injury. Again, I told you that most transolecranon fracture dislocations are bony injuries, But there are some of them, after fixing the bone, you find out that the ligaments, some of the ligaments may be injured too, and you may need to take care of them. Management in ED, you're going to double check if the bone, any open wounds, because it's a shear injury and a significant displacement. You may do some close reduction or pull on the arm and put a long arm splint. I think that usually is enough. You need to get a CT scan to be able to, not to miss any coronoid involvement in other fracture areas that may cause a big problem if you miss them, because sometimes they're not displaced and they may not be apparent on the original x-rays. You got to check the coronoid, radial head, and insertions of the ligaments are important. When it's a comminuted fracture around the lesser or greater sigmoid notch in the proximal area, I think you got to make sure that you know where this origin and insertions of the LUCL and MCL are, and if there's any impaction, obviously any periarticular injury. I usually put them in lateral decubitus position. I will tell you a little bit about approach and other things. So reduction, I think anatomic reduction is key, and Ed mentioned, Dr. Harvey mentioned about this PUDA. You may need to read about it. Some of the proximal ulnas, some people have a significant angulation of their proximal ulna relative to the shaft, so proximal ulnar dorsal angle. So in this cases, if you put a straight plate on it, you may be mal-reducing, and especially in Monteggia injuries, this may be a culprit of the persistent radiocapitellar subluxation or the dislocation. But you want to put it anatomically, the joint. You are usually using the cortical reeds as much as possible, even in the comminuted fractures. And I usually use a trochlea as a template if there's a significant comminution. There are two ways to access if there's a radial head fracture associated to it, either through the fractures, as you can see in these cases. I'm not going to go through it, but I go through the fracture, take care of the olecranon. There's a kind of a FATSI procedure because you're going to reduce the ulna provisionally after trial of the radial head or fixing the radial head and go back and forth and take it down. Or you need to create a separate approach for the radial head if there's a radial head involvement. You can take care of the proximal ulna, then create a separate approach either through a skin incision, but the deep approach, some kind of lateral approach, whichever you want to choose. So order of reduction, I start deep and go superficial like in terrible triad injuries. If there's a coronoid fracture, I will take care of them. If there's a coronoid tip, personally, I don't do anything. Then take care of the radial head if there's something broken or it needs to be fixed or replaced. Then coronoid base fracture or ulnar metaphysis, if there's one, take care of the impaction. The last thing I do, the olecranon, after fixing all the bony injuries, I will check the ligaments if needed to be. Again, associated ligamentous injury after something happened. As you can see on this picture, after fixing all the bony fragments, there was some subluxation of the ulnar-humeral joint. So you see there's an anchor after fixing the bone. I added an anchor to get the elbow stable. Again, this is an articular fracture. You need to have an absolute stability of the joint. Secure fixation of the coronoid. This is probably the most important part. The coronoid is really important. If it's broken and displaced, it's going to contribute to the instability of an elbow. You have to take care of it. You cannot say, oh, I hope it does well. You have to take care of it. Usually I use mini plates for comminuted fragments because you need to put like cortical reeds to get an anatomic reduction. Usually the final fixation, sorry, I'm going to show this again. So this is a kind of an olecranon variant, right? A severe olecranon fracture looking thing. I think that very few people are using the tension band constructs, but in this pattern, because it's a shear injury, I think, although you may not like the plates because of the prominence and other reasons, I think this one requires kind of a buttress with a plate for secure fixation. I don't think tension band will work well in a transolecranon fracture dislocations. I usually splint them 7 to 10 days, depending on if there's a little some instability. If they are perfectly fine throughout the range of motion as isolated bony injury and nothing else, I may let them move right away. Passive and active assisted range of motion. You're going to make sure that they start forearm range of motion too, because there's a PRUJ area is involved, there's comminution. You don't want to end up with stiffness, especially lack of supination. It's very hard to regain supination if they get stuck in supination after 6 weeks or 12 weeks. And after 6 weeks, they start gradual increase of weight bearing. Common pitfalls in this injury are suboptimal fixation. Basically not to fix the coronoid, especially. Either you don't recognize where is a coronoid fracture or you don't fix the coronoid very well and it escapes. or lack of restoration of the proximal ulnar anatomy, the PUDA that I mentioned. Again, not everybody has a significant angle, but if they have a significant angle, if you make them more straight, it's going to cause a problem in the other elbow joint, parts of the elbow joint. And tension band wiring may not work because there's a shear injury. I think requires a buttress with a plate. Thank you.